test. Good evening, and welcome to the first mini medical school of 2021. My name is Zoe Burrow. I'm a first-year medical student at IU School of Medicine here in Terre Haute, and I'll be moderating the session this evening. Mini medical school certainly looks different this year than it has in the past, but I'm excited to share the new format with you. I'd like to start the evening by explaining this format a little bit better. The Zoom webinar platform allows us to feature local expert panelists, and all other attendees will be muted and without the option of video. Many medical school attendees may type questions throughout the session using the Q&A button located at the bottom of the screen. Those questions will be addressed by panelists following a brief intermission after presentations. Tonight's topic is the COVID-19 pandemic and emerging infectious diseases. Before I introduce our first panelist, I'd like to take a moment to thank the sponsors who made this event possible. Hamilton Center, Inc., Indiana State University, Indiana University School of Medicine, Terre Haute, Lugar Center for Rural Health, Minority Health Coalition of Vigo County, Inc., Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana AHEC, and WTHI-TV. I would also like to thank all of our panelists for taking the time to speak this evening. And finally, I would like to thank all of you for attending tonight's session. I'll now introduce all of our panelists. Our first panelist is Roy Geib, who was a faculty member at the School of Medicine located on ISU's campus from 1984 to 2017, where he taught medical microbiology, medical immunology, and medical genetics to medical students and a number of other courses to ISU students. He served on several national and international committees related to communicable and chronic diseases. While serving in administrative capacity at the School of Medicine, he started the mini med school program in 1995. He has participated in many medical school sessions since it began over 25 years ago. Our next panelist is Dr. Daryn Burkin, an alumnus of both Indiana State University and Indiana University School of Medicine, Terre Haute. He graduated from IU School of Medicine in 1997. He completed the family medicine residency at St. Vincent's before returning to Terre Haute, where he worked at Terre Haute Regional Hospital. Daryn is currently the Vigo County Health Officer. He was recently named the recipient of the 2020 Douglas J. Leonard Indiana Caregiver of the Year Award. Our final panelist is Joni Wise, an Indiana State University alumnus who has served as the administrator of the Vigo County Health Department since 1997. She also serves the Vigo County Board of Education. She has been involved in a number of community outreach projects over the years related to communicable diseases and emergency preparedness. She's presented at several previous mini medical school programs in the past. Without further ado, I will hand it over to our panelists and we'll get underway.
Greetings. I'm going to be shifting in a second to a screen share option so that you can see the PowerPoint presentation. It's been quite a while since I've seen the group. In fact, I still can't see you guys, and I do miss seeing all of the attendees at past presentations. I know 2 years ago was the last time I spoke, and I said, well, that'll probably be the last time, but because of the new format, I'm speaking from Durham, North Carolina, and enjoying the warmer weather without those -8 degrees sessions that you guys had. So I am going to switch to screen share so that you can see some things. And it's been disabled. Maybe we can turn the screen share on. May need some help. Yucks. Okay, see.
I'm working on it.
These new sessions are great in many ways. I can talk to you through the magic of Spectrum up here and probably Spectrum in your area, but not everything's totally worked out yet. So, and that's okay. I think many of us have had an interesting year. You can see the long hair that I have because the last time I've been able to go to a hair salon or barbershop was last February of 2020. So it's quite up, maybe, nope. And we tried this before, we had it worked out. I got to see my PowerPoint presentation and Uh,
Try now.
Okay, we are trying one more time, and there we go. And share. Okay. One thing I would like to do in the very beginning is just to remind everybody, and I know Zoe's going to be making this announcement several times through, is to make sure that we take the polls both at the end, both demographic and survey polls as we've done in the past. The speaking order tonight is going to be me, followed by Darren, and then followed by Joni. That'll be the format. This is the title of the session, the COVID pandemic and emerging infectious diseases. I know that Joni and I have addressed you previously in the past about the emerging infectious diseases. I think the last time we may have done that was either with the flu or with, I don't know, was it Zika?
It
No.
might have been H1N1.
Might have been H1N1, or it might have been Ebola. I know this is a topic that the community has been interested in the past. One of the things I learned early on when I was in graduate school was I got pulled into the chairman's office with the other new graduate students, and he always said, make sure you tell them what you're going to tell them, and then tell them it, and then tell them what you told them. So key point here is to remember to wear the mask, wash your hands, and make sure you have enough distance. Keep that 6-foot distance. This is going to be the order that we're speaking in again, and the topics. Just as a reminder, I do not give out any medical advice. I give educational information, and I strongly recommend that if you do have specific concerns, particularly about possibility of exposure, talk to your healthcare provider. They're the ones who know you the best, and they're the ones who then would be able to advise you as to what is important for your specific health concerns. As Zoe mentioned, I've been around for quite a while teaching medical students, PA students, nurse practitioner students, graduate students, all dealing in the areas of infectious diseases. I've served on the National Institutes for Health panels related to HIV, and also for DARPA on some of the research that they were doing. And so I don't pretend to be an expert on COVID and coronavirus. I have a lot of knowledge, but if you've done any type of Google searching, if you've used Google Scholar, you see that there are literally within the last year, thousands and hundreds of thousands of articles that have been written on it. So it's impossible to stay up to date on all of it. But I think we can all agree that this has been an extremely long year as we look back. This is about where we were last year. You can see we've gone through a couple different peaks. The most horrendous one was back in November and December. And I think all of us had some really bad experiences during that period of time. I remember being in Florida the 1st of March last year, coming back from a workshop that I gave down there. We landed in Durham, then drove back to Terre Haute. I remember that first night that they were just starting to cover coronavirus. I remember going to a Kroger's up north, and I clearly remember a woman who was coughing and coughing, and her kids were saying, "Mom, you can't cough on people. Please cover." And she said, "I don't care. If I've got it, I want everybody else to get it too," which was an absolute horrendous thought to me, that people would be intentionally coughing onto people. And at that time, I don't think anyone could have predicted that within a year's time, we have lost over 500,000 people in the United States. That is just, it boggles my mind. I remember having a 4th-year medical student call me, a 4th-year resident call me. He was the previous medical student that I had, but he was finishing up his psychiatry residency in Georgia. And he said, Roy, is it going to get really bad? And I said, I think it'll be bad, but I don't think it'll be as bad as a very, very bad influenza year. And boy, was I way off on the mark. I don't think I expected the number of individuals to choose not to follow guidelines. So one of the things I want to stress here is information sources. Look for reputable sources and avoid the questionable ones. And we'll talk a little bit about that. Then I'm going to be covering some definitions of emergent disease, pandemic, endemic responses. I'll give a little bit of a brief overview of the viruses. Darren's going to be talking more about the clinical side of that. And I'll talk a little bit about the potential outcomes, why some people get severe diseases and others not. So I know what we all would like and what we were all hoping the medical experts would tell us right from the beginning is a clear, simple yes or no, don't do this, don't do that. And I know there was a lot of confusion in the beginning on when to wear masks and when not. And but understand that life is not always, this is the first time we've seen this disease come into the population. And our experiences are that everything is constantly changing. I know, having taught medical students for well over 40 years, one of the things that everybody likes, particularly medical students, is a black and white answer. This is exactly what I need to know. And then you say, this is what you need to know. But under these circumstances with this individual, this will be a type of presentation. And we see that particularly with this disease. We see some people who have been totally asymptomatic and who can still shed virus. We see some people being pretty sick, but then getting over it. And then we see others who unfortunately never left the hospital afterwards. So things change as we build on that. I can't help but to take a step back and remember that today is Dr. Seuss Day. That's important because I do remember that song in the movie at the Cat in the Hat, calculatus eliminatus, so that's pretty much what we've had to go through this year. People would study certain things and then we hear changes. Okay, wait, no, you don't need to wear the masks outside. Now we think we should be wearing masks outside also. So I would remind people that the more you read, the more you know, the more you learn, the more places you will be able to go. And so as we follow the directions from our healthcare, public health providers, hopefully that knowledge will lead to the happiness and we'll be able to ultimately get back to a somewhat normal life. But to do that, we need to get the facts and we need to stop falling for misinformation, because our lives and everybody's lives depends on it. I live in a 55 plus community down here, and some of the stuff that gets passed around on the bulletin board that we have is just so, I have no idea where people get this erroneous information, except that when I check around, that's generally coming from some particular sources, such as QAnon, and people just really get pulled into these things. So get the facts. And where do we get the facts? First, I'd like to point out that this misinformation is not new. Okay, back in 1889, the Russian flu was being attributed to the new light bulbs that people were using at the time, even though there was the Russian flu was existing in situations in which they had no light bulbs yet. So that information has been there. Then with the Spanish flu, It was supposed to be coming from a camouflaged German submarine that pulled outside in Boston Harbor and released a big cloud that flew across the whole United States and infected everybody. And when we even talk about the Spanish flu, which we've heard presented in the past, the first case was actually in Kansas. And the reason why it's called the Spanish flu was because every other country had an embargo on their news related to the influenza. Whereas, and remember at that time in 1918, they even had no idea what the flu was or the virus at that point. Nowadays, I've also seen stuff that says that it was the 5G networks that were responsible for COVID. And so all of this misinformation is out there. We need to stay away from it. I suggest, first off, look what's locally happening in your community, the Vigo County Health Department website, then go to the state, Indiana State Department of Health, then go to the Centers for Disease Control, National Institutes of Health. All of them have up-to-date good information. Other sources that I highly recommend are the American Public Health Association, a very reliable group. They have had lots of webinars which are available online. JAMA Network I find to be exceptional. You can look at their YouTubes. They have videos that explain the virus replication cycle, all in easy to understand information. You can also subscribe to news services, specifically Medscape and Medical News Today, or you can go and read articles at the Mayo Clinic or Johns Hopkins. So look for a reputable source and try staying away from all the misinformation that's floating around on Facebook. So getting back to our definitions, one of the things that we want to do is give a definition of what a pandemic is. And to be able to get down there, we need to understand a little bit about communicable diseases and what do we mean by pandemic versus epidemic. And a new term that I've seen coming, it's at least been mentioned in the news down here, is that people are saying that eventually COVID or SARS-CoV-2 is going to become endemic as it adapts and perhaps is not as bad and we respond. So endemic diseases are diseases that are normally found in our population. An example of that would be the common cold, or would be coronavirus before this particular strain hit. So coronavirus has been around for quite a long time, just not to the extent that we're seeing with this particular strain of the virus or variant. An epidemic is where we suddenly have a widespread occurrence of a disease in a community at a particular time. We've talked about these situations when we talk about H1N1 flu coming into the population. And a pandemic is when this is spread totally worldwide. And on the right here, what we can see is one of the reasons why these move so fast from an epidemic to a pandemic in today's society is because if we look at the airline flights, you can see that within a matter of hours, you can be from Asia into the United States and over into Europe. So it's one of the reasons why these diseases move so quickly. Two other important terms to remember on this. One is called emerging diseases, and that's a disease that's appeared in a population for the first time, and that's what this particular disease, it's an emerging disease. It crossed over species lines. But we've also had situations which are re-emerging, where a disease has been in a population and then has dropped out of the population and then comes back into it. So these are things to keep in the back of the mind, and they have occurred throughout the history of humanity. So influenza, every once in a while we get a resurgence of a different strain of influenza that causes a more severe a higher rate of morbidity and mortality associated with it. So let's go back to a really basic definition here. what do we mean by infectious or communicable diseases? These are agents, either viruses or bacteria, that are going to be passed from person to person or from an animal to persons. And we've seen this before. We have had several surges of E. coli throughout the last decade, where food sources have become contaminated with E. coli that were normally found first in bovine. And we see this, and we sometimes refer to this situation. We can see the overlap between an infectious disease that is an endemic infectious disease that's seen in the wildlife population and then can cross over into the human population, sometimes from a domestic animal coming in. So we do see these transfers around as we go over, and we have these spillovers or spillbacks in which these situations can occur. Sometimes it's because we're moving populations of animals around, could be due to agricultural intensification, could be changes in technology or industry. All of these things have different types of impacts that can change how a particular disease is presented and what the outcomes can be. So again, here's a cartoon that shows just a couple of years ago where everybody was worried about Ebola, and it's re-emerging in that population and then possibly spreading. I remember so many people being concerned about that, possibly coming to the United States. Then we've had Zika coming in from different populations. We have cholera breaking out periodically. So these diseases do come and go. And what's particularly concerning about this is the level of fear and death that we're seeing with the SARS-CoV pandemic. And much of it is because of some of the social misinformation that was being passed around that may have, if we had followed instructions earlier, followed guidelines earlier, may have greatly diminished the potential mortality. And I'm still concerned about the morbidity of long-term infections. So if we look at this virus, Corona does not come from the beer. The beer came after the virus was identified, but it does serve for the crown. If we look in the electron microscopy cartoon that's up at the top, you can see it does sort of look like that. There's a crown surrounding the viral particle itself. So the virus was named for its appearance in an electron micrograph. We can see on the surface on this cartoon that it has a very key component, and this is the spike protein. That spike protein is what is going to bind to the receptors on the human cells, and it's also the target. That spike protein is the target of the vaccines that are being developed, whether or not we're talking about Moderna, whether or not we're talking about the recently released Johnson & Johnson or the Pfizer vaccine. All of those are going to be targeting the spike protein because that is the place that we can have the greatest impact of being able to prevent future infections. Now, this virus, its genome happens to be RNA. So in our cells, we have both DNA, which then gets transcribed into an RNA, and then that RNA is then translated into proteins. Because viruses don't have both RNA and DNA, they are obligate cellular parasites. They need to infect us. This particular virus has only RNA genome, and because it's an RNA genome, it needs to replicate itself using an RNA-dependent RNA polymerase. That is extremely prone to errors and has a mutation rate anywhere from 100 to 10,000 times the mutation rate that we see in humans. Our mutation rate is about 10 to the minus 9 per nucleotide. This is much, much, much higher, which is why we're beginning to see all of these variants. Usually, coronaviruses have a fairly narrow host range. Okay. Unfortunately, because of the error-proneness of this replication process, these spike proteins may have mutated and then allowed it to cross the species barrier. Normally, coronaviruses are transmitted by aerosol. We can also see hand-to-hand. So when you sneeze into your hand and then shake somebody else's hand and then they rub their eyes or move it around their face, that's one possibility. We also have object to hand. One of the reasons I recommend getting, when you bring items into the house, you do wipe them down. And then we also have this other area, fecal oral route. This virus is being shed because of the way the receptors are throughout the body. It's not just causing an upper respiratory tract infection, and Dr. Brucken will be talking about that in a few moments, but this virus also does replicate in the intestines, and GI problems have been associated with the disease. And it's one of the concerns that I have when we're out traveling, particularly long distances. If you go into a public restroom and somebody is in a stall and they may have had diarrhea, they flush that toilet, and those toilets do not have covers on them, and most people don't put the covers down anyway, but it does create this wonderful fecal plume that the medical students used to laugh about when I would talk about it covering the entire inside of a stall, getting all over the purses that are hanging on the door and the handles. That fecal plume caused by flushing a toilet can go up to 6 feet of aerosol up into the air, which is a phenomenal amount, considering we're going to be sending kids back to school, and none of those schools have covers on their toilets. So that is a concern of mine as we try exploring those issues. But most often it does cause or replicate in the upper respiratory tract in epithelial cells, but it can also infect not through the upper respiratory tract, but it also, the receptors are also on the lining of the eye. So it's very simple to rub your eye. So try avoiding that. As we start responding to these infected cells, we have a certain level of inflammation that has been normal. That inflammation is a part of the immune response. And as part of that response, we also release a number of proteins which are referred to as cytokines, and they can also contribute to the pathogenesis. Many of us have heard the term cytokine storm, particularly related to this disease, and that's because it's pushing out so many of them. And we're now beginning to understand the relationship between this cytokine storm and the normal process of what's been referred to as inflammaging that we see with people who have diabetes, people who have arthritis, people who are overweight. We have a normal level of inflammation that's being built up as time goes on, and this is being referred to as inflammation. And now we're beginning to look at the added impact of this cytokine storm as it relates to the inflammaging. So normally this produces, coronavirus is produced just a normal pharyngitis, a normal cold. Rarely were we getting pneumonia and gastroenteritis. One of the things we do know about this virus, coronavirus in general, is that reinfections are possible and do reoccur. And we are beginning to now see this in some patients who have been diagnosed with coronavirus and are now getting it infected again. So our typical coronavirus is endemic in humans. We've had it with us for long periods of time, but this new SARS variant is a zoonotic spillover. It came in from another species, and typically when we see that, even with the influenza viruses, which do this quite regularly, come in from other species, that the disease then is much worse as it moves into that new population. And that's exactly what we saw with this SARS virus. So if we look at this, we see that frequently people present with a fever over 105. They have that persistent cough. They have general body aches. That's all part of the immune response. These cytokines are also responsible for that. They generally don't feel well and they seem somewhat depressed. And again, the cytokines are responsible or impacting that. We now know that one of the main drivers of this is a cytokine called interleukin-6, which is also very linked to depression in individuals. We see shortness of breath. And then I recommend that people, when they start having shortness of breath, definitely use a little device here, which just tells you, okay, well, my oxygen levels are dropping or not. But there's also the possibility of significant lung damage and systemic organ damage. And I think Darren will be going into more of that. I want to stress this last one here, the long haul syndrome. I was just reading an article yesterday about a physician at Emory University in the emergency department. He was asymptomatic, except that he suddenly lost ability to taste his delicious yogurt, as he describes it. They were never able to get a positive virus test on him, but he's been out of work for over 6 months because of just a total loss of energy, even though he has never shown positive virus production. So they've never been able to get a positive viral RNA test from him. But clearly, he has all the other components of it. And so we want to make sure that we recognize that even moderate individuals can constantly being pushed out the virus. Virus shedding is individuals even before they start showing signs of the disease. But after they do show the signs of disease, we can have moderate or we can have really severe. And when we see this really severe situations, it's because of that huge cytokine storm that is being produced. So why do some people get the disease and others? Some of it we can control, okay? We cannot control. We can't control either our genetics or the genetics of the virus strain that we get. That's a given, but both of those play a role in this. Just last week, gene associated with Neanderthals that gives the possibility of a lesser disease. But 2 weeks before that, they were talking about a gene from the Neanderthal population that many of us carry that actually makes the disease worse. So we can't control that, but that's one of the reasons some people have a worse disease. Other issues that play a role in it are going, and I'm sure Darren's going to be talking this. Most of the population that's attending medical school in the past have been over the age of 60. Okay, usually a little bit older than that. And we're all in that category that is impacted by age. Immune status. It could be because of that inflammation, that constant inflammation that we built up over the year, but immune status is also influenced by stress, lack of sleep, which I've never seen a medical student have enough sleep. social determinants of health. Frequently, this has to do with ability to get to the doctor, ability to get into for vaccinations, ability. There's various things that play into that social determinants of health, which is why we see differences in certain demographics as to their susceptibility. The last thing that I'd like to point out along this is the root of the infection, whether or not we're breathing it in. We can prevent that, or at least modify it by wearing a mask, and then trying to make sure that we have a low infectious dose. Again, by wearing the mask, being careful. Nobody knows exactly what the infectious dose to produce a disease in a human is at this particular time. The most recent study that I've seen looked at hamsters and 5 virions, which is not a lot, many more in a single aerosol droplet, but 5 virions was sufficient to cause a disease in the hamster model that they're exploring. So again, key point on this, remember the 3 W's. Wear the mask. That cuts down on your possibility of infectious dose, but also stops you from giving it to somebody else. Wash your hands frequently, whether or not you're using soap and water, which is very good, or a disinfectant, and then watch your distance. And then the other thing is get the vaccination when your time comes up. Thank you. And stopping share. Okay. It's not going away. And it's not responding. I'm going to turn it over to Zoe because I can't do anything from my end.
Okay, unfortunately, I may not be able to do anything from my end either. Unless you have any ideas, Ms. Mathis?
How about that? I can log out and then log back in. That might clear it. I'll do that.
Joys of technology failing this. I'll hand it over to you, Dr. Brucken.
Okay, thank you, Zoe. Thanks, Dr. Geib, and Joni too, who's following me right after this. So my name is Darren Brucken. I'm a 1997 graduate of the Indiana School of Medicine. I've been a practicing physician for 24 years now. It doesn't hardly seem like that, but it sure has. I'm a hospitalist physician, so I do everything within Terre Haute Regional Hospital. So most of my patients are on the adult wing. I do see pediatric cases as well, but the ICU is under my charge as well. So I've been seeing COVID patients from a medical standpoint since the very first one arrived here in town back last March. So and then the other hat that I wear is the Vigo County Health Department Health Commissioner. So oversee the Department of Health and all of our contact tracing, and Joni and I work hand in hand on all of the aspects of public health. So it's a unique perspective for me because I have the experience with the patients, and then also shift gears and deal with public health perspectives as well. So Dr. Geib asked me to speak a little bit just about the clinical impact of COVID. It's a topic that, you know, I could spend 9 hours on, probably sitting through and talking through the nuances of this. I tried to shrink this down the best that I could to some very basic premises. I will tell you that in doing this for more than 2 decades, and in speaking with my colleagues, we have never seen a reaction like this. We've never seen a clinical cascade like this, when somebody goes from being kind of okay and 4 hours later they are dreadfully ill and headed towards a ventilator. It's an inflammatory cascade that it's like nothing we've ever seen before. And the coronavirus, you know, as Dr. Geib pointed out, is not new. We have experience with both SARS from 2002 and MERS in 2012. as far as the beta coronaviruses. In practice, in the United States, we didn't deal with any of that. A few of the people that work at the CDC might have traveled and had a little bit of MERS background, that type of a thing. But SARS 2002 disappeared off the face of the earth after a year. So we didn't have to worry about vaccine rollouts and those types of things. So when people come in, when they get sick, I'm gonna, unfortunately, I'm not quite as tech savvy as Dr. Geib was here, but I'm gonna go old school and just kind of put my TV up here behind me with some slides. Let me get that started here as well. So it's gonna be kind of like an old fashioned presentation here, hopefully. We'll see. And I hope you guys can see this. How's it look, Zoe? Can you see it? All right, it's spectacular. Okay. Take my word for it, it's spectacular. There's a coronavirus right up there. Just want to talk a little bit about the effects on the body. First of all, there's 115 million cases worldwide right now. More than 2.5 million lives have perished because of this disease worldwide. In the United States, we have more than 29 million cases right now, and 553 have died as of this morning. Those are data that's up to date. So it is spread host-to-host transmission, and that's from large droplets and small aerosols. So this is it's a respiratory borne virus. It may not be a respiratory virus, and there's splitting hairs there, but it is spread from one person to another. So you have to be in close enough contact. There is no vector with this. This is not an insect-borne illness. This is not equine encephalitis virus. This is strictly from one person to another person, and it enters here through our upper airway. This M-spike protein has a tendency, it's a lock and key format, and it will bind to the ACE2 receptors found very prominently in human epithelial cells, particularly in the upper airway. But that ACE2 receptor is pretty much ubiquitous, though, in humans. It's in a lot of other organs as well. We find it in the lungs and kidneys and in the liver and the heart, myocardium, in the GI tract. And depending on the age of the person, you see a higher predominance of ACE2 receptors in the upper airway of most adults. We see a lot more higher percentage in kids in their GI tract. After inoculation, a host of symptoms occur, and these are cold and flu-like symptoms, just as Dr. Geib was talking about. You may get, chest discomfort, headache, malaise, kind of flu-like symptoms more than anything. You may not get fulminantly sick very quickly, and a lot of these people have innocuous symptoms, and they don't really feel like they're sick. We hear every single day, and Joni will tell you, everyone thinks, oh, it's my allergies, or I have a head cold, or this is my sinuses acting up. When in reality, when we're doing the tests and we're detecting this is SARS. But the breadth of the symptoms goes from asymptomatic to death. And in my own experience, I've never seen anything in my practice for sure that it either does nothing to you or kills you. Nothing is that cut and dry and that broad spectrum like this particular virus. So patients, when they develop COVID, when they test positive, I get the question asked to me a lot, am I going to die from this? I boil this down very simply put. I said, two kinds of people die from this disease. The two serious body effects are lung involvement and blood clotting disorders. That is really what causes people to perish. Okay, if you get GI symptoms, if you have diarrhea, you're going to be fine. You're going to have a hell of a journey, but you're going to be fine. You're not going to die from this. You could always have your one-offs here and there, but we worry mostly about lung involvement, and we worry about blood clotting cascades. Those are the two types of significant or serious effects that this virus can have on the body that will eventually kill you if untreated or unchecked. So this, hopefully you guys can see this. This is a model of basically the terminal air sacs, the alveoli of the lungs. We have our bronchus that comes through here. We have arteries and veins through here, and our terminal air sacs. And this is what is our functional importance for life, where carbon dioxide and oxygen are exchanged for one another. We're breathing in oxygen. The veins are taking back and putting our waste product back into the airway for exhalation. That is gas exchange. This is a mock-up of a terminal alveolar sac. This is what goes on, what we see in the hospital situation. Okay, I'm hospital based. I'm not an outpatient doctor any longer. So people don't come with a headache. When I see them, they are there because they're sick and that they've already been screened in the emergency room. They're hypoxic, they're on oxygen, and they need some help. This is the fundamental process of respiration, where carbon dioxide can leave our blood vessels and get into the terminalveolar sacs. Oxygen can be exchanged across this very permeable membrane through here. That membrane, I often talk about, is analogous to a spaghetti strainer and water pouring through that strainer. It has to be permeable. And what happens with COVID cases is there's this massive immune response where the body starts laying down fibrin material and all of this network of these inflammatory markers. And we start to develop a sludge through here. It's like taking filter paper and starting to stack it up inside of your strainer. And if you think of the water going through as your oxygen getting to you, suddenly you don't get as much oxygen. And your waste product, carbon dioxide, can't go the other direction. So we start to inhibit respiration at the cellular level. And this happens in all of these little air sacs as we go. The progression of this, these are CT images, these are axial cuts of normal lungs over here. Normal lung is black lung. These are blood vessels through here. To the staunch comparison of a COVID-19 lungs, this is somebody who is sick. White lungs is never good on a CAT scan. So this is what goes on with all of these terminal air sacs are just devoured by this process. Now, what we see from that, we watch their x-rays and we watch them progress. We have normal appearing x-rays here on the far left coming through. This would be somebody who shows up in the ER. These are the phone calls that I get every day where they say, hey, somebody is here, they're COVID positive, their SATs are 86 on room air and they're 94 on 2 liters. So they're comfortable. They need hospitalization for continued help. No matter when we intercede, hardly the very rare, I guess, circumstance stays like this. They usually progress a little bit further before we can get it to stop. One of the important things that we are discovering now is that when these fibrin materials, this ARDS pattern, this pulmonary fibrosis pattern, whatever you want to call it, this stuff doesn't go away. It doesn't regress and turn back to normal. We don't see that. 6 months later, your lungs might look like this. They're not going to look like this again. We still have not seen complete resolution, and that's because of the scarring that takes place. So it's really akin to like a pulmonary fibrosis type of pattern when we see it. When you're sick and in the hospital, this is ARDS. That's adult respiratory distress syndrome. People are sucking so bad to try to suck in and actually inhale the air through their own resistance through here. We have to use positive pressure ventilation in order to push from the other side, because again, we're trying to push air through that now semi-permeable membrane, and the patients are using all of their muscles. They are inspiring with all the power that they typically have. And if you are 40 going through this, you do a lot better than you are at 80. So the host response certainly plays a big role into that, and just how healthy you are going in. You know, how do we treat? Well, we start out with mild cases. We're just using a nasal cannula, just the 2 little prongs up the nose. I will say in practical experience, we see a good portion of this right now, particularly people that come through with constitutional symptoms, a lot of GI onset, a lot of fever, and I just don't feel good, and they test positive and they're 90% on room air. We can get them by with a couple liters of oxygen. We start them on our appropriate therapies, and most of them do okay. If they don't do okay, we move to step 2. I know this is probably hard to see, and I apologize for that, but this is heated high flow oxygen. And these are basically prongs that go up the nose, but this is heated oxygen at higher rates of delivery and a little bit of pressure behind it as well to help offset that resistance that we're trying to deal with. When heated high flow fails, we move to BiPAP. And for non-medical people who might be tuning in, BiPAP is like a jet fighter mask. It is a tight seal around the face. It's strapped to you. We are pushing air in, and we are pushing air in because the body, these people are sick. They cannot do it on their own. They're trying, and they still have to coordinate their breaths with BiPAP. These people are not on sedation. And I would tell you from a mental standpoint, this is one of the hardest things to tolerate because people are awake, they are fighting, they are anxious, they hate this thing. I've worn one myself to see what it felt like, and it's horrible. But this is one step removed from mechanical ventilation. That's really pixelated on my end. I hope you guys can see that, but that's mechanical ventilation. That's a double-edged sword. It's a double-edged sword for us as healthcare providers, because when we get to this step, the patients look peaceful because they're sedated. They're basically in a medical coma state, so that respiratory distress is gone. And when family members are able to come to the window and glance in and see their loved one, gosh, they think they're getting better. They're not. And the mortality of somebody on a mechanical ventilator is enormous. It's 85%. If you're over the age of 70, do not come off of a ventilator. So 15% are able to make it. That goes up with age. So if you're 86 years old and you go on a ventilator, no chance. Our younger patients do have a fighting chance if we can get to them early enough and they have enough lung stores left. There's the med students that are tuning in here tonight will talk about Ecmo. Ecmo is not really in widespread use. It's basically a lung bypass machine. The reason Ecmo does not work with this is because when we bypass the lungs and you start out with really, really terribly diseased lungs, when you come back to it in a week or 10 days or 14 days later and you hook people back up to their lungs are still diseased. So Ecmo fails. We are not broad spectrum saving people by Ecmo. Plus they're not available. We have probably less than 10 available in Indianapolis, the entire city. So we can't save everybody with that regardless. The other thing we look at is the blood clotting. We check our D dimers and our inflammatory markers. There's lots of studies out there now that show that COVID is actually capable of expressing cardiolipin antibodies in about 12 to 20% of people. And it develops this massive tendency to cause blood clots. Now, these may not be your classic blood clots that cause giant PEs and big DVTs in the legs, but microthrombosis. We see that like crazy. We'll do a D dimer on somebody, which is a blood clotting test. If it's positive, we look at their legs and we look at their lungs. Like, well, there's no clots there. We can't see them. They're probably there, but we just can't see them because they're not large enough. But microthrombosis is often responsible for heart attacks, strokes, PEs, perhaps some of the long-term cardiac effects, because we will see persistent cardiomyopathies following COVID in a good number of people. Placental clots, right now is a hot topic about whether or not pregnant ladies should get vaccinated. I've taken care of a COVID born baby as well, where the placenta in the moms who deliver in their third trimester while infected or recently reinfected with COVID, they have hundreds and thousands of little microthrombosis in their placenta by pathological exam. So we know it goes on, but pregnancy itself is a hypercoagulable state. And these people are prone to microthrombosis. This just makes it worse. The same goes for kidney damage. When we look at post-mortem examinations of COVID deaths, they all get kidney failure. The longer you're there, if you're in the ICU, we keep them running on the dry side anyway. Nobody survives it with perfect kidneys, and we will see microthrombosis all throughout the kidneys. The liver, we see it there as well, and we can see it in the brain as well on autopsies. And perhaps some of the long-term neurological issues, persistent hypoxemia that takes place with these people. And when I say persistent and chronic and those types of terms, what people need to realize when you go into the hospital with run-of-the-mill bacterial pneumonia, you're in 3 days, 4 days, maybe 7 days if you're really, really sick. If we get a COVID patient with respiratory failure and they leave the hospital within 21 to 28 days, we're ahead of schedule. We had people in the hospital for 90 days with this, and they may or may not ever leave. We've had people, 56 days in that then deteriorate and die on that day. So it's a long, long process to try to get all the way through this. But we focus a lot in the hospital on breathing and blood clots, because nothing else is really going to kill you. So we have to focus on that. What treatments do we have? I'm a biochemist by training, been a physician a long time. I've seen a whole lot of disease states. I'll tell you that we have a cocktail of supportive care. There is no, kind of gangbuster treatments that are just off the chart. This is really going to work very, very well. When people come to the hospital, we hit them with remdesivir. It's an antiviral agent that basically interrupts the replication cycle. It's not a cure-all. You can't give it to people with renal disease because there's a metabolite that can cause seizures. But all it's been proven to do is shorten someone's hospital course by a few days. So it's not something like I've got to get remdesivir in me, otherwise I'm a goner. It's an adjunctive measure. It helps, but it's not something we hang our hat on. Steroids. Historically, when this pandemic first hit and we got guidance from the NIH and the CDC and the WHO and everyone else, all of these specialists, they said, absolutely do not give steroids to these people. Hold steroids, don't give steroids. To me, way back when, and the people that know me well knows that I was jumping up and down. And if I had hair, I would have pulled it out, saying we have to give steroids. This is an inflammatory cascade. This is this evolution of cytokines and prostaglandins. We have to interrupt the inflammation. The virus itself is not cytotoxic. It's not like it goes in and directly kills a kidney cell or directly kills an alveolar cell. It's your body's inflammatory response. So we said, well, don't give steroids. That was based on the 1980s influenza data. And someone extrapolated that. If you give steroids to somebody with active influenza, it prolongs your shedding. That's where that recommendation came from. Now we do just the opposite. As soon as somebody comes in, we hit them with steroids. And even now, I'm a proponent of higher steroids because of the amount of inflammation that's present. So corticosteroids, this is what I hang my hat on every day. Higher doses, be aggressive because you need it in people that are critically ill. High dose vitamin C. How crazy is it that in 2021, we're recommending a vitamin for use for a life-threatening illness? Vitamin C, it's a huge cofactor in mammalian enzyme reactions that we need. And when people are critically ill, well, there's been tons of studies showing that vitamin C deficiency will actually inhibit your ability to heal and to help yourself. So we give this. It's a water-soluble vitamin. It works fine. It's innocuous. It doesn't hurt anything. There's been good outcome studies with it. And finally, convalescent plasma. That's donated antibodies basically from people that have recovered from COVID, someone that previously tested positive and fought off the illness. This also, a lot like remdesivir, has been shown to limit someone's days in the hospital. It's not something that we breathe this giant sigh of relief, like, oh, thank goodness we got them convalescent plasma. We throw it on there. It's an adjunctive measure as well. Does it help? Probably a little. Is it a cure-all? Absolutely not. And that's what we do. But when I tell my patients when they're in the hospital, I'm like, we're going to give everything that we can do for you up front, but ultimately it's your body that has to fight this off. And if you, again, take someone who's 60, they have a whole lot better chance than someone who's 93 or somebody who's 74. And you guys know from looking at patients too, you can have a 75-year-old, thin walker, jogger, still works on the weekends at Lowe's. And then you can have a 62-year-old diabetic's already had a stroke, has had bypass surgery and everything else. So we look at our risk factors for disease states because they play a huge role in how well somebody does. And that all just tracks with common knowledge and sense. Monoclonal antibody infusions. All right, this is bamlanivimab and then Regeneron. Important thing that people kind of lose sight of. These things make a lot of news stories, but monoclonal antibody infusions are not for sick people. These are for people that test positive who may not do well with the disease. So people that have risk factors over the age of 55 with diabetes, over the age of 65 in general. This is done up front. This is done as soon as you test positive. Within 10 days, it has to be given. These are basically monoclonal replications of neutralizing antibodies. This works. I will tell you wholeheartedly this works because we have seen our nursing home patients go by the droves that test positive during an outbreak at a facility, and only 1 or 2 come to the hospital. 28 of them stay home and they do really well. They get sick. The ones that really benefit from it, they get sick for a day or two of high fevers and they feel terrible. But ultimately, that's what a neutralizing antibody is supposed to do. It's supposed to neutralize the response. And that's what goes on. We also have a JAK2 inhibitor, Janus kinase inhibitor. It's called baricitinib. We use this in combination with remdesivir. This particular agent a lot of people said, hey, this could be it. We've been using JAK2 inhibitors for a long time for immunology and some other issues with cancer care, with platelet inhibition in particular. It's not a godsend either. It's kind of a fancy steroid from what it does. And the fact that we use it with remdesivir in combination, that's how the FDA approved it. We don't personally use it at regional hospital. I've not been impressed by this one at all. You know, and again, we can sit and talk for kind of hours and hours and hours on end about the ins and outs of what we do with the nuances of mechanical ventilation and the steroids and using medicines to prevent blood clotting. Hopefully you guys have some good questions, you know, at the end. I wanted to keep this kind of brief to allow for a lot of questions. My last slide basically says the promise is being realized, and it's being realized by vaccination. Okay, vaccination is unequivocally our way through this pandemic. 3 vaccines are out there now. We have seen unbelievable studies and data, particularly from like Israel, who's leading the world right now in vaccinating people. You know, keep in mind that if we can get people over the age of 60 vaccinated, that represents 93% of the deaths that we have in the United States are people over the age of 60. That is not to say that people under 60 can't die from this. I've had a 35-year-old and a 39-year-old pass away fairly recently of this. We had a 32-year-old that we lost here not too long ago as well, that carried up an extensive amount of comorbid conditions. We have very few pediatric deaths across the country, which is wonderful. This does spare kids, and there's a variety of reasons for that. It probably kind of supersedes, you know, the discussion here tonight. But the vaccines, that's the way through the pandemic. You know, I was first in line, and we were fighting over each other to get in line first and foremost. And it's a pretty good segue when we talk about vaccines to the public health response to this. And I'm like setting Joni up here, so this should be perfect for her. And she'll explain it to you. You know, what we do from a public health standpoint starts at identification, contact tracing, figure out how this works, how this spreads, how this interacts, and then figure out solutions. And then not just solutions on a local basis, but mass solutions. And that comes from vaccine. So at that point, Joni, I'm going to kick it over to you. And again, we're all going to be available for questions afterwards. And thank you for your attention. Sorry for the old school presentation.
Okay, hold on here. Screen share. There we go. I'm going to talk about the Vigo County Health Department's COVID-19 response. We at the health department had a 4-pronged response. It was through collaboration, contact tracing, education, and vaccination. My little guy's too big here. On March the 3rd, 2020, Union Hospital brought together a lot of the community partners and to look at this emerging situation and what we needed to do as a community. There were lots of things that we didn't know at the time. We didn't know, you know, how much testing would be available. The information regarding the disease was kept evolving and changing. But the one thing that we did know is that it goes back to what Roy said in the very first, his very first slide, and it was about information sources, reputable versus questionable. We knew that what we could do is get together and disseminate accurate, timely information to our community partners and to the public. And so what we did that day was develop what's called a Joint Information Committee, or a JIC. And through that JIC, we were able to get information out to the public. Every Wednesday at 2 p.m., we do a JIC phone call, and people give their reports on what's going on within their discipline. On that call, we have people that are state representatives. We have people from the county government. The mayor of Terre Haute participates when he can. The Vigo County Health Department gives out our report. Union talks about what's going on there, whether it's testing, how many people are in the hospital, what their hospital capacity is like, how many COVID patients. they go through the whole gamut of what's going on and what they're seeing at the hospital, and regional does the exact same thing. We also have higher ed on there. We have Rose Holman, Ivy Tech, ISU, St. Mary's, and they're talking about what's going on at their institutions. What things they're trying to do to mitigate, what's going on with in-person classes or remote classes, whether they have testing on the campus or not, how they are quarantining students. So we go through a gamut of things. We also have the public and private schools on there. They talk about what's going on within their discipline. What are the challenges that they're seeing? Sometimes they ask advice from other agencies that are on the phone. We also invite long-term care on there, and they do the exact same thing, talk about the status of what they're seeing, challenges of the virus being brought in for the outside, those painful decisions like how much do we lock down our residents and for how long, and again, keep them from the disease being brought in from the outside. Chamber of Commerce is on there because we know this has affected our local economy. We have safety that gives their report. The EMA talks about what's going on from their perspective. Terre Haute Fire, are they seeing a lot of runs? What kind of runs that's going on? The EMS is on there. The 181st, they've been extremely helpful as a resource. Law enforcement, whether it's Sheriff's Department or the City Police, and then Central Dispatch, because they get to hear all the different calls that can come in. They'll say that right now we're seeing more calls than we did last year at this time or last year at this month. And a lot of those are respiratory related or the symptoms of COVID. So all those things come into play. And then our faith-based community is a very important facet because of they can disseminate information and help us be part of the solution and not the problem. March the 18th, Vigo County government closed along with city government. Everybody was sent home to work except for us at the health department. You can see we're on March 19th, we had our first person test positive, and it just continued to go up to where Roy was talking about, that peak we saw in November and December, and it came after a lot of the states, including Indiana, lifted some of the governor's directives. And then you compound that with an absolutely perfect Halloween weekend with a full moon on a Saturday night, and it created total havoc with Thanksgiving as an accelerant. Contact tracing, gosh, what a buzz term for 2020. It's interesting to me that people don't realize that contact tracing is such a fundamental piece of what we do. In Indiana, there's the diseases that are deemed reportable. The health departments are HIPAA exempt. We have to have that information come into us in real time, because if somebody presents at a doctor's office versus presenting at an emergency room, that doc and those ER people aren't going to know that there's a pattern of diseases going on. Since they're reported to us in the time frame described, we can start to see patterns that are going on that we think we have an outbreak here, or let's take a closer look at what this might be. We have our CARES Act fund pays for our contact tracers. It's been interesting. Many of them are taking gap years between medical undergraduate degrees and medical degrees, or they're taking a time between their undergrad in epidemiology and their master's in epidemiology. We at the health department joke that they collectively raised the IQ at the health department, but it's been super refreshing to have them use this experience as a learning process, and hopefully, and I'm sure it will, help them in the long run in whatever they do professionally for the rest of their lives. Every business day at 10 a.m., we have a briefing, and all the tracers come together. Dr. Brucken calls in. School corporation is here. ISU has a representative, and we sometimes have elected officials pop in. And what we do is we go over all the cases. And with that, you start to see commonalities, you start to see hotspots, you start to see challenges that we might not have thought about before. And but contact tracing, again, is something that we do every day for all those diseases that are deemed reportable in the state of Indiana. So it's not like we're invasive and getting into people's business. It's what we've always done. Here's a picture, some photos of our merry band of contact tracers. We even had poor Luke over here that had just graduated from Penn, and he had the summer off before he went to Microsoft. Had to be forced to go to Microsoft because he loved it so much. Now his parents are mad at me because he wants to go to med school. This is a photograph of our 10 o'clock briefing. As you can see, everybody's masked up, and we give our reports. And again, like I said, you start to find commonalities and hotspots. As we can see, one of the contact tracers put together an impromptu presentation showing us how it took from patient 0 that went to an out-of-town party and how it spread. You can see how it went to a pool party, went to other people. And then the photo over here, there was a kegger party, more people were infected, and then went to a graduation party. Now, a more glamored up slide would be this one. This is the same thing that Lily was presenting, but this is the official one that was utilized by the chamber in our community. But just goes to show you how it takes that one person and then away it went. This is how we were able to do our contact tracing again, say, hey, something's going on, or let's be on the lookout for this. Education is a huge piece for what we do. We're fortunate to have a health educator and media coordinator. And every day on our health department website and social media, we post exactly what's going on in our community. On our website, we also have links to ISU and St. Mary's and the chamber, and they can post information up there also. So somebody can do a one-stop shop if they want to know what's going on in our community. They can click on and see what the health department information is we're disseminating. They can see what the school corporation is disseminating. So instead of going to all those different entities, again, it's just a one-stop shop. Well, Ronnie had to learn to do her interviews different, as we all had to, and that was utilizing Zoom to communicate with the media. One of the other tools that we used was a panel discussion for the public, and we had CEOs from the local hospitals. Dr. Brucken was there. We had a pulmonologist, one of our elected officials, and the public was able to email questions in, and we had Kristen Craig from the Chamber of Commerce act as our facilitator and giving us those questions. Huge positive feedback from the public, because this was around the end of April, maybe the third week of April, and there was just so much disinformation and fear flying around, and it helped. I think it helped empower people, knowing that they did have things that they can do to help them lessen the chance of getting COVID. And then also knowing that as a community and as professionals that are with this response, that we were responsibly taking care of it and taking care of it seriously. There were also panel discussions on different television stations that were live that again brought on a panel of experts to answer questions, whether it was from the medical standpoint, the EMA, or the public health standpoint. We held press conferences that were live streamed. Every week we disseminate information via graphs, and you can see again when we had lulls and when we had spikes. We always wanted to make sure that people didn't get a false sense that they're okay. Those numbers are high because we have so many people down at the FCI, inmates and staff. Well, we always made sure that we took those numbers out and made sure people could see which ones were ISU students or which data belonged to the federal prison, and then what was just our community-based statistics. Had to learn to do interviews in person with a mask, of course, and this is taken down at our Sears clinic. Ronnie did a walkthrough with the media and allowed them to see what the clinic looked like and what the throughput was. Well, now we're getting to the good part, a little bit of light at the end of our tunnel, and it's our mass prophylaxis clinics. We get a lot of feedback from people saying, wow, how did you do that? It went so smooth. In 2006, in January of 2006, Vigo County stood up the first mass prophylaxis exercise in the state of Indiana, and it was completely full scale with the strategic national stockpile being brought in. And so this is one of the things that we do and we do well. We have kept the Cipro and Doxy for the U.S. Post Office here in Terre Haute that has a biological detection machine. So if we had to mass prophylax employees that had come in contact with any type of agent that would come through, like anthrax on the mail, we've exercised that and ready for that. We had the largest chickenpox outbreak in the United States and had to stand up mass prophy clinics. In the past, when there have been vaccine shortages, flu vaccine shortages, we've stood up clinics at the fairgrounds where we ran 1,500 people through in a day. So when you see how well our clinics work, know that there's been lots of years of practice in real world and in exercises to make sure that we can do it as best we can. It was well received. The first 90 appointments that opened up at the annex were taken within a few hours as soon as it became available on the Zotec platform. Our Sears clinic, and our first clinic opened up at the annex, like I said, January the 11th. Stood our clinic up at Sears on February the 1st. We did it in the old automotive center, which was the brainchild of Commissioner Brendan Kearns. We didn't really want to do a drive-through clinic in January. We wanted something, or in February, but we wanted something that we could start out with, that we could still get numerous people through the clinic. But when warm weather hits, when we're still doing this, that we could open up those auto bays and be able to drive people through. So it's really a super good idea. Dr. Adler, the health officer in Tippecanoe County, said they tried to emulate it up in Lafayette, but the store wouldn't go for it. But fortunately, we did here in Terre Haute. Lots of staffing and volunteers, whether it's the staff from the health department, our EMA. In the past, we've used students, nursing students, medical students. They've helped us throughout the Hep A outbreak that we saw in the Midwest the last few years. We have the clinical instructors and the students from all the entities that are named on the screen. We also had a lot of our retired and current nurses throughout the community, along with physicians that wanted to volunteer and are volunteering to give the vaccinations. We've had dentists come forward to help out. We have our community response team volunteers called CERT that have been coming in and helping out. The community volunteers, the EMS. So it's been phenomenal, the response from our community for people wanting to see this thing succeed. Here's a look at our clinic, and it's during one of those setup stages, and so you don't see a lot of people, but that's kind of the point. The platform that you can register on to get a vaccine will only allow for each vaccinator 10 minutes per person. In all reality, we could do 2 to 3 people easily. I mean, do a person every 2 to 3 minutes if allowed, but again, the platform won't allow us. So we only have so many people in at a time. Currently at the Sears location, we're doing about 240 people a day. We do have the capacity to do up to 5,000 people a week once we receive enough vaccine. You can see some of the individual getting his vaccine. We have EMS presence outside at all times. 2 of our contact tracers, they're helping down at the clinic. This one's doing a gap year between med school. This one between IU at graduate degree in epidemiology to going to IUPUI for his master's in epidemiology. You know, standing up a clinic takes tons of logistics, and I don't think people really can wrap their head around all the different logistics, such as, you know, designing the throughput, all the supplies that you need. And I had one of our staff design the annex clinic, and then I had a nurse an A&P that had retired from us, and she had designed most of our large clinics that we had in the past. And so she came on board and did a very labor-intensive design of our Sears clinic, along with Dr. Doreen Hoyneke, which we've worked with for years. We know each other's assets and resources. We have our incident commanders and our backup incident commanders. We have 2 individuals that oversee the registration of patients. They oversee the registrars that that enroll the patients. We have Grant Hammonds and Jake Schmidt. They oversee all the schedulers that set people up for second appointments. We have one of our retired nurses that coordinates the vaccinators and the scribes. You have an individual that's responsible just for the vaccine storage, the drawing up, that the chain of custody from the time it leaves our clinic to go down there, to the refrigerator, to drawing up, to in somebody's arm. There's an accountability for all those stages, so we know exactly where we are on doses. And then we have a person that's responsible for when the people go to take that have gotten their vaccine, to go into that little corral for that 15 minutes or 30-minute window. And then we also have people that are our meter and greeters. The thing that we've heard the most from people is just how simple it was, but also that they love that warm handoff from the time they show up at the exterior door to the person opening the door as they exit. It's worked out really well. Again, we have the platform we use is called Zotec. It only allows that 10-minute time frame for each person. We receive 1,200 doses each week, so that's about 240 people a day. And we could, like I said earlier, have the potential to do over 5,000 doses a week if the vaccine becomes available. And so this response that I've described to you, especially the contact tracing and the education, since last year, around March the 3rd, tomorrow, a year ago, we've worked this 7 days a week. You know, COVID doesn't know it's the 4th of July or a Saturday or a Sunday evening. And it's pretty common that we put in 12 to 14-hour days. The first actual holiday that all of us took off was Thanksgiving. That goes to show me that's a really long haul, but we're passionate about public health, and that passion's what has helped carry us through in our response for our community. And I know a person that absolutely hates needles, but I went ahead and got one anyway. I'm optimally immunized. All I need to do is be chipped, and then you guys can put me up for adoption. Hand it back to you, Zoe.
All right, thank you so much. Wow, I learned so much even just sitting here tonight. Thank you to all of our panelists. We're going to take a 5-minute break at this time. And as Dr. Geib mentioned earlier, I'm going to mention there should be a pop-up window that appears on your screen, and it's just to collect some basic audience information. So if you just please complete that for us, make your selections and click submit. And then I just want to remind you that as attendees, you can type questions using that Q&A button. It should be at the bottom of your screen, and we'll address them after intermission. I'm so sorry, but right now I'm not seeing any on there, but as you're sitting here kind of thinking over on the 5-minute break, if you have any questions, you can put them in that Q&A feature. But for now, feel free to stand up, stretch your legs, and we'll see you back here at around 8:02. You guys. The first question is, does everyone who's had COVID have the scar tissue in their lungs, or is this limited to patients with respiratory symptoms?
I assume it's probably directed to me. So yeah, not everybody that is test positive for COVID has respiratory symptoms. So so it's not an invariable attribute. So if you do get serious disease, pulmonary complications, when you leave the hospital, basically you're going to have scar tissue in your lungs. That's what got you there to begin with.
Great, thank you. And then our next question is from the chat. It was just announced that the Texas governor has opened the state up 100%, and there will be no masks tomorrow. This is dangerous, and how will it affect the country?
Who do you want that? Who do you want to answer that, Zoe?
Oh goodness, make me make the choices. I guess whoever would like to answer. I think probably most directly pertains to Dr. Geib and maybe Ms. Wise as well.
Yeah, I think looking at the numbers, you know, I think it's a bad move. I would hate to see that happen all over the place. I would suspect then that's going to push us to another surge. I'm actually quite surprised that we didn't have a bigger surge after Super Bowl Sunday, but I'm not sure that's where those numbers are going to roll in yet. So I don't know.
Yeah,
I don't like it.
I'll jump in as well, and I'll be even less passive about my answers. I think that's the dumbest thing in the universe that the state of Texas can be doing. You know, this entire pandemic has been wrought with political divisiveness, and to have people unmasked and coming back together, you know, not mitigating while we're trying to vaccinate, it's foolish and reckless behavior. You know, we have over 4,000 variants of this virus already that have been identified in the world. We have several hundreds that have been identified in the United States. And at any time, variants can undo all the progress that we've done to date. You know, we talk about South African variant, the Brazilian variant, all of those things. Those are the ones that gets the attention. But as Dr. Geib pointed out earlier, RNA viruses are sloppy replicators, and they're prone to mutations and deletions and substitutions. So we don't know what the future holds, and to take the foot off the gas pedal right now is absolutely ludicrous. Glad I'm not a Texas resident.
I'm glad I'm not Texas also. I agree with you.
Governor Holcomb had said something last month, and it really struck home with me. It said, "What I don't want to do is sacrifice any of the approaches that we've taken that have gotten us to this day," Holcomb said. "Here we are trending in the right direction. I almost grieve at the deniers and defiers because that just means everyone else has to do more or stand by and watch." What a powerful statement.
From my experience or opinion, one of the worst things is to see the total disregard for the healthcare professionals. These are my children. I've taught medical students for 40 years. I've taught nursing students. And to see people disregard and then go in and possibly infect Darren or any of the other, it's just so heartbreaking to see a total disregard for that when something as simple as a mask. I came back in with my mask because I was just seeing my grandchildren who were here, even though they are not going to school, and my daughter is a healthcare provider also. We are concerned about this. We wear masks inside because they're in a slightly different pod. It just makes perfect sense to try preventing it from getting into somebody else. I don't understand the rationale other than for political gain, as Darren pointed out. Utterly stupid to take that possible slip back. So I will continue to wear my mask when I'm out. And I hope you all do the same.
So I certainly will as well. I did want to make a note in our little Q&A box. We did have someone who said, "Thank you for your time and valued information," and God bless as well. And can definitely mirror that. Thank you so much for all of your presentations tonight. We have another question. After receiving both vaccine doses, what precautions should we continue to take? And I think maybe Ms. Wise, will start with you.
Well, precautions to take would be doing what we're doing now, which is to wear a mask. I'm optimally immunized, but I don't want to give anyone the false sense that it's okay not to wear a mask around for others. So I'm going to still continue to live and act like I don't have the vaccine.
I agree with that.
We still need to wash our hands and socially distance also.
I agree 100% with Joni on that. I am also optimally vaccinated. I would remind people that the vaccine is predominantly pushing an IgG response, which is very protective against systemic or lung, but not necessarily stopping somebody from being able to develop an upper respiratory tract infection and still be able to shed the virus and infect a loved one. And we saw how easy that was spread at the parties that Joni's contact tracers pulled in. It goes very quickly. The RO on this is still pretty high as far as the number of individuals that are infected from a single individual. That's still a fairly high number, and we just don't have enough experience to know whether or not fully vaccinated people are still going to be able to possibly become infected and shed virus. I don't know what your feelings are on that, Darren.
Yeah, exactly the same. You know, right now the population, the demographic up to 59 years old, they are not vaccinated. The 60 are halfway vaccinated right now. For us in healthcare that are vaccinated, for us to walk around unmasked like we're invincible, you know, that's foolish behavior as well, because the optics need to be there. Number one, you know, I don't feel I'm full PPE with my COVID patients. It's not because I'm vaccinated, I'm suddenly immune to it. So we don't really understand what's out there. And I'll further it even farther by saying, you look at the influenza data right now. You know, influenza, we still, knock on wood, we're not dealing with it in the Midwest right now because of the masking and the distancing. And the amount of burden that's alleviated from a healthcare system is amazing too. And that comes from masking and distancing. It's not like influenza went away, it's still here. So, you know, everyone needs to still mitigate as we vaccinate. And once everybody is vaccinated, we see that R0, that R naught value fall off, where we can collectively breathe a sigh of relief from an epidemiology standpoint. Yeah, then it makes a lot more sense to start saying, let's get back to some sense of normalcy, but not until then.
All right, we have a couple more questions over here in Q&A, and they're actually for you, Dr. Brucken. So what was your personal experience with family while working with COVID patients? Did you live away from your family or stay with them? And how did the hospital handle the staff coming and going?
Yeah, it's evolved. You know, this was a moving target from day one. And I will tell you that when we first were learning how the virus acted, we were all terrified, you know, to be around it, to work with it. And when, you know, I did not stay away from my family, but when I came home, I had a change of clothes. I changed in the garage. I went right. My wife and daughter went to the other side of the house. I showered fully. And of course, you know, the attention to PPE detail, COVID or non-COVID patients, we are full PPE for every single patient. We've had a mask on since day one, and our hospital has been religiously following that. We have had healthcare workers, you know, test positive. Usually not from patients. They actually get it from one another, from social gatherings or whatever else. And that's you know, attributable to the PPE use that is there. As we've grown through this, I work with it every single day. I'm very comfortable around it now, even before vaccination. So I know it's not mythical and magical. I know how it's going to get into me if it's going to get there. So I take every precaution that I possibly can with full PPE. I still change my clothes before I come in the house, type of thing. I'm more lax now at home. I come home, I'm around my daughter, around my wife. Neither of them are vaccinated because of their age. But, you know, like I said, there's a comfort level for me and from all of us frontline people that work with it every single day. It's not that we're not fearful of it. We are a little bit, but we're respectful of it, and we take our right precautions. So we can walk, you know, confidently and comfortably around it now.
Can I just add to that? My daughter's experiences have been exactly the same, making sure that the clothes and everything change. I think if I thought anything in the public health domain that should have been changed, and that was making sure that the healthcare providers' families could also be vaccinated. The healthcare providers have given so much, but yet their families are at significant risk. So that would be the one thing I would have recommended to our state and Indiana's state departments of health at the higher levels to say, okay, let's make sure that the families are the first responders in the medical communities are also immunized early on.
And
I can stay home. They can't.
you know what's interesting about that? I've worked with both union and regional on their closed pod plans, and a pod's a point of distribution. both of those hospitals do have that written into their plan that families would be taken care of.
Mhm.
Again, this vaccine is, the usage of it is delegated by the State Department of Health.
Right. And I did notice that I have a colleague at one of the medical schools in Pennsylvania. Her family was also totally vaccinated because she was at risk. So even though they were not part of the high risk group as far as age is concerned. So it makes sense, but I understand limitations on the number of vaccines at the moment also.
All right, and then we have a question. Is there a concern that lungs will never return to normal post-COVID recovery? Dr. Brucken, I believe that's to you as well.
I'm like a pulmonologist now. So, there is a concern, because it chronic lung disease, and one of my close colleagues, Dr. Deshpande, that I work with every day on all of our ventilator patients, all of our BiPAP patients, everyone that's been through with chronic disease, he sees them back in the office 6 months later. They're on inhalers. Many of them are still on oxygen therapy and those types of. Like I said, we don't see significant regression of the X-ray findings. So, and that owes to the pathological process at the cellular level. It's a massive inflammatory cascade that leads to all of this collagen and fibrin cross networks that just lays down scar tissue. And it's not like a scab that you can pick off because it's deep in the lungs. So, and we do see people, and what Dr. Geib spoke of, long haulers, these people that are still short of breath 4 months later. They can't walk a flight of stairs. Their x-rays may not be all that impressive, but their pulmonary functions show that there's residual damage that's there. But, you look at the caveat, they're alive.
And along those lines, yes, I think there's going to be long-term residual. I'm also concerned about the long-term residual effect related to mental health, neurological issues. The ACE2 receptor is not just on lung or intestinal epithelial cells, if we pointed out, but there are significant issues related to infections of the nervous system also. One of the key first things people sometimes respond to is the fact that they no longer can taste. If that part of the neurological system is going to be impacted, plus the long-term or the high inflammation rate, mental health issues are going to be a significant part of the long hauler syndrome. And I will put a key in that next week our speaker is going to be talking about the mental health issues related to COVID and the help that is available in our community related to that. But from a psychoimmunology perspective, I am concerned about that long-term effects also, besides just the lungs.
Yeah, and I'll add to that, Roy, and that's an excellent point. I'll add to that with the mental health standpoint too, is a lot of things are going to be COVID adjacent. And if you look at what's happened to the education system, Joni can speak to this as well. The impact that it's had. She sits on the Vigo County School Board, and she hears this every day. And we have our conversations about how do we get kids back in person learning. The impact from the educational setbacks, the financial setbacks. The hospital systems have lost $200 billion during the pandemic. So people have lost jobs. Obviously, businesses. So huge socioeconomic impacts are going to reign forward for decades.
Absolutely. Yeah. No.
Thank you. And then we have another question over in the chat. It says, our adult daughter and husband are coming for a visit. Both are hospital chaplains. We all have both vaccines, and they will overnight in a hotel and can share a meal safely. And can we share a meal safely, in the house and visit with masks?
Yeah, absolutely. Because you're taking the right, recommendations from people to be smart about it. Sitting across the table, you're all vaccinated, you're all in a situation. Particularly the adult daughter, as long as that's an adult daughter and not a high school daughter that is not vaccinated, because people can't carry it in. We know that the efficacy of the vaccines, once you get your time allotment, depending on how well the vaccine works, and which vaccine you've received, the chances of contracting the virus from somebody goes down by 95% on average. It's probably a little bit higher than that if you look at the Israeli data. So if everybody has been vaccinated, nobody comes in symptomatic, and you keep your distance and you wear your mask and you keep your close face-to-face interactions limited, home free. It's a good setup.
Did I hear young grandchildren?
I don't believe so. It's just adult daughter and husband.
Okay, yes. I know that with my grandchildren, we eat without the mask, but they're at a separate table 6 feet away, and I do have a HEPA filter running in the room the whole time.
All right, that is all I have on questions. Unless there's any last minute questions, we do have another comment on the chat. It's so great to see all of you and to understand what you're so informed with. We were unable to participate in mini-med last year, so to be able to do this on Zoom is absolutely marvelous. And then note for Dr. Geib that the snacks here at home aren't quite as healthy as those at Landsbaum.
Well, that is a big issue. I've got a little bit of both, but it's healthy snacks are something good to work towards. I know I have relatives who said that over this COVID period, they've actually gained weight at home because of letting to get out. So exercise at home, take good care of yourselves, continue your home health screenings, doing blood pressure, eating healthy snacks. I do appreciate that they did always like the cookies. I did also. And I also like the fruit snacks that we used to have. So I miss everybody. But I am really thankful for Zoe for moderating, and Darren and Joni for participating here. It was good to see a student give a great presentation. I remember Darren when he was back in medical school. And wow, knocked my socks off, Darren. Thank you.
Yeah, thank you. This was a great opportunity. It's a great example of how these three facets of science and immunology and the medical impact on patients, plus the public health response to find a way through this pandemic. I mean, all three of those things are interwoven on a daily basis, and add to it other things like mental health professionals and economists and psychiatrists and psychologists. It's going to take an entire village to get everybody through this, for sure.
Absolutely.
So this was a great meshwork of three big facets of the response.
I found a book in my office, and it was Milestones in Public Health over the last 100 years. And I thought, well, guess what? We get to add something to this. We get to add the pandemic.
Oh, yeah. And I am very impressed with Vigo County's response. So,
Thank you.
Excellent. And really appreciate the help of our AHAC director in getting us on the line here. Wow.
All right. Well, if that's it for this evening, this will conclude tonight's mini medical school. I want to thank our three wonderful panelists once again for all of your insights and for answering questions. And thank you to everyone for joining us and for all of your questions. I hope that you'll join again for mini medical school. It's every Tuesday in March and April from 6:30 to 8:30 via Zoom. And before ending the meeting, we just ask once again that you answer the questions that appear in the pop-up on your screen. The feedback is completely anonymous and will be used for planning a future mini medical school sessions. Thank you once again. I hope you all have a wonderful evening.
Thank you all. Yes, you too.
Bye.
Thanks.
Bye.